But here's the prostate cancer prevention trial. And the reason this never, ever got on television in the United States will become very apparent shortly. Okay, the 5-alpha reductase inhibitor people, 18.4% cancer. The placebo, 24%. So isn't the finasteride better than placebo? Well, look at the next statistic. Aggressive cancer in 37% of those who took the 5-alpha reductase inhibitor. Of the ones who got cancer, which was 18%, 37% of them were highly aggressive. In the ones who took the placebo, there was significantly less aggressive cancer. So, this is why it never got on TV, because the TV commercial would have read like this. Take our finasteride, you'll get less cancer, but when you do, you're more likely to die. Imagine them putting that on TV. Okay, and this is just a long elaboration of the same thing. Increases the risk of high-grade cancer disease, all those 5-alpha reductase inhibitors. Oddly enough, that's because they inhibit so severely. Now remember, there are natural 5-alpha reductase inhibitors. One of them is called Zinc. And does zinc increase the risk of prostate cancer? Yes, if you use over 100 milligrams a day. There's a paper on that. Who's the last one of you who prescribed 100 milligrams or more a day of zinc? Nobody. That would be kind of stupid. That's going way past what nature does. All right. So this is from the Cochrane database. You're familiar with the Cochrane people over in the UK who review things, and they're not funded by government and they're not funded by industry, so they're a tiny bit more believable than others. And they're saying information is inadequate to assess the impact of 5-alpha reductase inhibitors on mortality. You know, in our newspapers, in the States anyway, back around that time, when is around that time? Before 2008, we were being told that all men over 40 should go on 5-alpha reductase inhibitors. Yeah. And even the federals noticed. They put a warning and precaution label on there. New safety information, more serious form of high-grade prostate cancer. Yeah, if you take those things. So, like any other patent medicine, as everybody here knows, one of the reasons I'm so glad to be here is I don't have to convince anybody here that patent medicines, which are molecules never before found on planet Earth, because you can't get a patent on them if they're found on planet Earth anywhere, shouldn't be used. They just shouldn't. They're always going to cause trouble. It's very, very predictable. Okay, so this is another trial. Men on dutasteride compared to placebo had an increased risk of Gleason Score 8 cancers. Yeah. I'll quit hammering on 5-alpha reductase inhibitors and just go through here. Okay, so here is our MAP pathway again. 5-alpha reductase, we want to activate this step over here to the 3-beta adiol. We don't want to go to 3-alpha adiol. We want more of that. Okay, now, testosterone metabolites. That's a report on a testosterone metabolite test. And what's it telling us? Oh, the testosterone, the DHT, the 5-alpha 3-beta, which is the good guy, as it were, and the 5-alpha 3-alpha, which is the bad guy. And what's that ratio about on the bottom? It's the ratio between the good guys and the bad guys. It's very much like the estrogen quotient that Henry Lemon came up with. Women who had more estriol than the sum of their estrone and estradiol were much more likely to be long-term breast cancer survivors than women who had less estriol than the sum of their estrone and estradiol. Well, this ratio is the same. You take the two carcinogens, the DHT and the 5-alpha 3-alpha one, and you add them, and you divide it into the 3-beta, and on this one you get a 1.5, as you can see on the screen there, you get a 1.5. The broad range is 0.8 to 6.5. I really prefer to have a 1.0 to 6.5 myself because I want more of the good guy than the bad guy. I mean, this is very simple. Out of when I was watching Westerns on TV, you want more good guys than bad guys. Now, this is a 38-year-old guy who was losing his hair, so I got to take a 5-alpha reductase inhibitor, don't I? Well, at least he thought he did. And look what happened to his ratio down there at the bottom. And that ratio is worked out again by dividing the bad guys, the 5-alpha, DHT, and the 5-alpha androstenedione 3-beta 17-beta adderall. That's the good guy. That's divided into that. But you add the 3-alpha and the DHT, and you get that low ratio down there. Again, the math is being done over here. That's what math we're doing. 3-beta divided by DHT and 3-alpha. 3-beta divided by DHT and 3-alpha. And we've got a low ratio. And that's why you have a high risk of highly aggressive prostate cancer, because you've cut your 3-beta back too far. Now, you can measure 3-beta. It's very measurable. It's a serum test, but it's very measurable. Okay, research on 3-beta-adal, the anticarcinogenic testosterone. This is one of the first papers published on this thing. It's an estrogenic metabolite of testosterone. Our mothers got into us again, guys. It's an estrogenic testosterone. Our mothers are protecting us because it only hits estrogen receptor beta. And estrogen receptor beta is all over the ventral surface of the prostate gland. Imagine that. So we have an estrogen receptor coming to our rescue. Us guys do. And it's stimulated by this androgen called 3-beta-adal. Well, us guys get back at you ladies, because research also shows that one of the first estrogen receptor stimulator in the female fetal brain is 3-beta-adal. No kidding. Here comes an androgen getting into young ladies' brains before they were born. Now, so it goes both ways. So, moving on to the next thing, but a potent modulator of estrogen receptor beta expression. For the one person who may not know about estrogen receptor beta, it is anti-proliferative and it's a reorganizing receptor, whereas the alpha receptor, that leads to more disorganization of cells and it promotes more cancer. I'm not going to say it gives everybody cancer. No. But it does promote it, and the beta receptor works against it. Oh, did I just say what's on this slide? Or PowerPoint, excuse me. Yes, I did. Now, there's a nice title, so I think I'll actually read it. The androgen derivative 5-alpha androstenedione 3-beta 17-beta-adal, otherwise known as 3-beta-adal, inhibits prostate cancer cell migration. Nice. Through activation of estrogen receptor beta. And there is our citation, if anyone wants to look it up. Always good to have citations to look up. It inhibits these migratory properties, but induces a broader anti-tumor phenotype by decreasing proliferation rate, increasing cell adhesion, reducing invasive capabilities. Gee, that's good stuff. How come we haven't heard about it? Because you can't get it. You can help your patients make their own, but you can't get it exogenously right now. And as it says here, 17-beta estradiol will not do this. That contacts the alpha receptor too, as well as the beta receptor. Okay, now they're getting down to saying on this one, the effects here described entail a novel potential application of this agent against human prostate cancer. We have out here a potential cure for human prostate cancer, and we can't get it? Talk about being a rebel. We need to march on the offices of the so-called authorities in health. And you know, anytime you have a government authority, you have this problem. You've heard the old saying that those who can, they do, and those who can't do, they teach. You've heard that? Well, it goes further. Those who can, they do. Those who can't do, they teach. And those who could do neither, they regulate. Because they don't know enough to do it and they don't know enough to teach it, so they get a position of power and regulate it. We really do need to be rebels there. There's a prostate cancer cure out there, potential cure out there, and we can't get our fingers on it. But our patients can make more of their own. That's kind of a helpful note. Okay, here's a whole bunch of mechanisms of action that are in the literature, and I really don't know, for example, what snail 1 is down at the bottom. I've looked that up, and I can't find out what it is yet, but there are a lot of known mechanisms of action is the point of this PowerPoint. Oh, and this PowerPoint, too, is just telling us high Gleason grade cancers exhibit much more of this and this, which are inhibited by the 3-beta-ADL, and this snail has moved itself into the nucleus. Apparently, the snail crawls into the nucleus from the cytoplasm when you've got a high Gleason score. I have no idea what a snail is again, but that's what it does. And the estrogen receptor beta slows that down when it's stimulated properly. So what do you do? Because the stuff is unavailable. I know I'm going to bitch about that a lot. It's unavailable, and it shouldn't be. Nobody ever got hurt with this stuff. You know, if this came on the market in the United States, it would be a controlled substance? Yeah, because it's a testosterone. Even though nobody ever got hurt, it would be a controlled substance. Such logic in politics. Okay, but T3 will stimulate it. Make sure everybody's T3 is up to where it belongs. Then we have NADH, which is kind of pricey, but you know, you can get the same out of a gram or 2 of niacin. Your body will make its own NADH. I'm sorry, I said that wrong. Niacinamide. A gram or 2 of niacinamide, and the body will make its own NADH. All right, lithium. Lithium helps to stimulate. I got to mention a new book because somebody asked me to write a foreword for it. That's why I guess they asked me to write the foreword. It's called Nutritional Lithium. If you haven't seen that, it's a paperback. It doesn't take you too long to get through, but the footnotes and citations are excellent. It's called Nutritional Lithium. It's by Dr. James Greenblatt. Green and B-L-A-T-T. He's a psychiatrist, and he's used lithium in his practice. He was kind enough to say ever since he was in medical school and read some of the stuff I wrote about lithium, low dose. There's a whole bunch of stuff one can do with low dose lithium, just bunches and bunches. I'd highly encourage you to get the book. One of the things you can do is stimulate your 3-beta-ADL, but there's bunches of things. It's an anti-cancer thing. Lithium, no kidding. It slows down the enzyme called GSK, and that enzyme contributes to cancer progression. So anyway, lots of stuff about it. It'll be in the book. Coconut oil, olive oil, remember those 2 oils? Yes, make more 3-beta-ADL. All trans-retinoic acid, if you want to go there. I rarely have to go there because these other things are a little safer and they work well. And there's that gold, if you get some gold into people. So I think you saw this one before, but let's see. Olive and coconut oils in the red, and how they stimulate the 3-beta and the 17-beta. Those are the enzymes now. 3-beta-HSD, 17-beta-HSD, they take the 5-alpha-DHT and turn it into the 3-beta-ADL. So what these researchers have done is shown that these enzymes are stimulated much more by the olive oil and the coconut oil than by the grapeseed or soy oil. A very significant difference anyway. I know one guy who got his 3-beta-ADL up there because he loves coconut oil, and he just takes 3 tablespoons a day. He just loves the flavor, and he chows down on 3 tablespoons a day, and up went his 3-beta-ADL. So it can be done with a single agent, too. You don't have to use all of them. Okay, and there's our 2 enzymes there stimulating the production of 3-beta-ADL from 5-alpha-DHT. And there, the citation is the last one. And the summary: animals fed olive oil, coconut oil, higher levels of antioxidants, and more of the 3-beta-ADL. Okay, I'm going to make a small detour into already established cancer risk ratios. There's the estrogen quotient. These are more applicable, pretty obviously, for women. The estrogen quotient, estriol divided by the sum of estrone and estradiol. That actually is done for you by most labs who test those 3 things. They're usually on the urine test because urine is accurate for estriol, and you cannot get an accurate reading for estriol in the blood. Remember the half-life.